Excellent. So hopefully you can see my shared screen. When I try to change the view of this, that's not in the way. All right, well, thank you, Kiara, for the introduction and also for the invitation to be a part of Science Series. It's my first time doing this. Hopefully there'll be other opportunities in the future. I know that I'm talking to a pretty broad audience, and so I have very basic stuff about what the kidneys do to what kidney transplant is and going into depth on how we manage kidney transplant recipients. And so, there are probably going to be a lot of questions along the way, and I'm, as mentioned, happy to address that as we go along. All right, so I'll go ahead and get started. Depending on how things are going, there may be time to take a little break in the middle, but I think we'll see how the timing is working out. So here is my course title and objectives for today. So I'm going to just start off by going over overview of chronic kidney disease and end-stage kidney disease, talking about the burden of disease and causes of kidney disease. And then we'll go on to talking about kidney transplant, which is my specialty, and discuss that this is the main treatment choice for kidney failure, although there are other options. We'll talk about the history of kidney transplantation within that and the kidney allocation system within the United States. And we'll also talk about some eligibility and outcome data. And then I'll end on some general discussions about how we manage patients after their kidney transplants. All right, so starting with the overview, this is very basic, but still very important to understand. What do the kidneys do? So the main functions of the kidney is they filter blood and they produce hormones. So under the filter functions, they help to remove fluids, they help to remove toxins that build up, and they also help to balance our various electrolytes and acids in our body. And then for the hormone function, the kidneys actually produce hormones that help us produce red blood cells. So one of the signs of advanced kidney disease is people start becoming anemic as they have an impairment in the production of these hormones. Kidneys also produce a bunch of hormones that are involved in blood pressure management. And sometimes it can be a little bit of a chicken and an egg scenario, like did the kidney disease cause the high blood pressure, or did the high blood pressure cause the kidney disease? But there's definitely an interplay there. And lastly, the kidneys also produce hormones that are integral in our bone health. And so people who have advanced stages of kidney disease and end-stage kidney disease are at higher risk for fractures and a variety of bone disorders. And so here's just the picture of, anatomically where our kidneys are connected to the bladder. But just basic physiology, our kidneys have a renal artery and a renal vein. And so blood goes into the kidney through the renal artery, and it gets filtered through this nephron, which is composed of a glomerulus. And it's basically just a network of blood vessels and little filters that help filter the blood. And then the blood comes out through the renal vein. Throughout all of this, you're producing urine, and that urine ends up in our bladder. So I know super basic, but this is kind of what the kidney is doing all the time, constantly filtering blood throughout the day and producing urine. So in terms of burden of kidney disease, 1 in 3 Americans are actually at risk for kidney disease. So it's pretty burdensome. So I mean, there are many people in the room right now, and so that's just puts it in perspective that a number of people are probably at risk for kidney disease. There are 37 million people in the US who have chronic kidney disease, and we'll talk about the staging criteria for kidney disease shortly. And there are over 660 people living with kidney failure. So that's people who need dialysis and people who have kidney transplants as well. And so in terms of causes for kidney disease, by and large, the largest cause of kidney failure in the United States is still diabetes, with 38% of people who end up with end-stage kidney disease or having kidney disease in general having diabetes. And then number 2 on that list is hypertension. And then number 3 on that list is glomerular disease. And I hear that someone's going to be talking about IgA nephropathy, which is a cause of glomerular disease. And so there are numerous glomerular disease, autoimmune disease can cause that, lupus can cause it. nephrotic syndromes, which are caused by a variety of things. So there's a lot that's covered in that group. And then you also have cystic kidney diseases that account for about 15%. And then everything else is sort of in this other category. There could be congenital diseases. Could be born with like congenitally small kidneys. And so those kidneys don't develop normally. There are genetic causes like autosomal dominant polycystic kidney disease. Infections can cause it. Autoimmune diseases can cause this. Just having other health conditions like heart disease, liver disease, sickle cell disease, medications. So there are a variety of other things that can cause kidney disease as well. But again, the leading causes are diabetes and hypertension in the US.
And Ade, we do have a question. Ruth asked, do you think the prevalence of kidney disease is higher in the US because of our high sodium intake?
So actually, it's not the highest in the US, but yes, our, dietary factors definitely play a role, but kidney disease, actually, I didn't really necessarily delve into that in this talk. There's a disproportionate burden for Black and Brown people. So, like, people of African descent also have a very, very high incidence. In fact, they're 4 times more likely to have kidney disease than Caucasian people, and that travels across the continent. So, like in Africa and like West Africa, where there are some genetic variations that cause kidney disease, there's also a really high burden of kidney disease there. And dietary factors also probably play a role there. There's high sodium diet, high red meat diet. So these types of things also probably contribute to the burden of disease. So risk factors for kidney disease. So, I mean, there are non-modifiable risk factors, but kidney disease, the risk of developing it increases as you age. And so you can't really kind of get away from the aging process. If there's a family history of kidney disease, either because, there's a genetic reason or other health conditions that sort of run in the family and put people at risk, but, there can sometimes be clusters. And then race, like I just mentioned really briefly, like we know that people who are in the US, Black people, Native Americans, and Hispanics are at higher risk than Caucasians for developing kidney disease. And then things that maybe we can get around with. So kind of talking about like, is it high sodium diet and just the things that we do that lead to obesity, high cholesterol, those are obviously modifiable things. So, watching our salt intake, having healthy diets, exercise are important. Those are modifiable risk factors. Smoking obviously increases your risk for cardiovascular disease, malignancies, etc. And those processes also can lead to the risk of increased kidney disease by causing heart disease, hypertension, and just vascular disease. Diabetes, we've already talked about other health conditions, like I mentioned previously, heart disease, liver disease, and then medication. So people take a lot of medications for other health conditions. And I think having, a primary care provider or specialty provider that's kind of aware of the risk factors of different types of medications, even pain medications like ibuprofen. Sometimes people develop, you're in an accident, you have really developed back pain, and not knowing that if I took, 2 grams of ibuprofen every day for a year, that would be really bad for my kidneys. There's just not a lot of awareness, I think, for common medications that people can easily get over the counter and their role in causing kidney disease. And so just education and just screening are important tools to helping people modify their risk of developing kidney disease. And thank you, Kiara, because I'm not monitoring the chat since I'm looking at my presentation. But yeah, if there are any questions, feel free to stop me.
I'll help monitor, no problem.
Thank you. So diagnosing kidney disease. So again, prevention is like key. So, it's important for people to have good primary care and be going for preventative visits annually if they can. And if you're someone who, is insured and you're actually accessing and utilizing your care, then when you're seeing your primary care doctor, things that they should be doing on an annual basis is just getting basic blood tests. And the basic blood tests they get will include a creatinine, which is the marker of kidney function. It's filtered by the kidneys, and it's an easy test to get to see what the kidney is actually doing. Creatinine in itself is not dangerous. So You could have high creatinine levels and another test we use is the blood urea nitrogen. They're not harmful in themselves, but because they are filtered by the kidneys, they kind of let us know what the kidney is actually doing. So using the creatinine, we're able to get something called a glomerular filtration rate. It tells us basically how much the kidney is filtering. And based on that, we can give you a number, which I'll go over in a little bit, that tells us where your kidney function is. Urine tests are also an important screening tool. More people will get blood tests and urine testing. Usually, if the creatinine is fine, someone might not think to get a urine test, and you might only get a urine test if you're a woman who has a UTI or you're pregnant or something like that, then you might get urine testing. But generally, it's a good screen to do at a primary care visit because it's easy. And what the urine can tell you is if there's blood in your urine, if there's protein in your urine, those could be signs of kidney disease. And finding those things early can maybe lead to diagnosis earlier and treatment earlier. So it's not uncommon where I would hear someone say, hey, I was seeing my doctor for years and years, and no one ever said I had kidney disease at all. It was just like an all of a sudden diagnosis. I felt really sick and I went in and they're like, your GFR is really low and you have this much protein. But, sometimes we'll look back to see if that person has ever had a urine test and we'll see that they did actually have some signs of protein loss or blood in their urine. And perhaps if someone was paying attention to that, maybe they might have been referred a little bit sooner for diagnosis. Imaging is also part of diagnosis. So when someone is known to have kidney disease, getting an ultrasound of the kidneys is an easy thing to do. You can see if they have polycystic kidney disease. So if they have numerous cysts in their kidneys, that could tell you what the diagnosis is. Do they have kidney stones that are blocking the kidneys? Those you can diagnose a lot of structural abnormalities by getting a kidney ultrasound. You can also see on ultrasound if the kidneys are scarred and shrunken. The radiologist will often tell you what the echogenicity of the kidney is. So basically how white it looks on the ultrasound. And so based on those factors, they can tell you that whatever is going on has been going on for a very long time. And the last tool that we have for diagnosing kidney disease is a kidney biopsy. So if none of the information you have is helpful, so you've done your blood testing, you've done urine testing, you've gotten imaging, and there are also a lot of other blood tests that you can get once you know that someone has kidney disease. You can screen for lupus, you can screen for infections. There are lots of things you can do. But if those things are not helpful, like you still don't know what's going on with the kidneys, then you can do a kidney biopsy. People who have long-standing diabetes, especially uncontrolled diabetes, who have protein loss, don't tend to get kidney biopsies because usually, unless the progression doesn't make sense, then they might get a kidney biopsy. But because most of the time what we find is diabetes, you don't have to diagnose someone who has classic signs of diabetic disease. So they already have signs of diabetes in their eyes with retinopathy. They already have neuropathy, and then they have lots of protein loss in their kidney. That's pretty classic for diabetic kidney disease. So not everyone has to have a kidney biopsy, but there are times where you're like, we don't know what's going on. We don't have an explanation. Those are the patients that you would move forward with a kidney biopsy on. So the stages of kidney disease. So stage 1 kidney disease just means that you have some form of kidney damage. A normal glomerular filtration rate is actually above 90. But if we say you have stage 1 kidney disease, it means that we already see that you have some signs of kidney damage, either because you have some amount of protein loss, some amount of blood in your urine, or you have imaging findings of abnormalities. So you have already cysts in your kidneys. Maybe you have polycystic kidney disease and a family history of that. So that puts you at stage 1. So if your GFR is still preserved above 90, that's stage 1 kidney disease. You get to stage 2 kidney disease when your GFR starts to come down. So you have some form of kidney damage, but now your GFR is now down to 60 to 89. And then there are stages 3A and 3B, basically means that you have further decline in your GFR. And stage 4 kidney disease means that you're there's a severe decline in that GFR. And so the implication of these stages is that typically once you have advanced to stage 3B or higher, these are patients who a primary care provider should be referring to a nephrologist. So, these patients should be getting medications to help slow down progression, and just getting long-term follow-up, and also, if the progression continues, these are patients that can then be prepared to have dialysis by getting fistulas and getting educations about their dialysis options, whether it's hemodialysis, peritoneal dialysis, and also kidney transplantation. So early referral actually also is very critical in making sure that first patients are treated appropriately, they get right medications, they are on the things that can slow progression, and then they get educated about their treatment options when they develop end-stage kidney disease. So end-stage kidney disease is stage 5. So when your GFR is less than 15 and or you're on dialysis at that time, that's stage 5 CKD. So the signs and symptoms of kidney disease, I think one of the things that makes it really tricky is that there are no symptoms really early. And so a lot of people are shocked that they have kidney disease because they're like, well, I felt well first. I didn't have any symptoms, but there might be signs. So patients may have some signs of foam in their urine, which could be a sign of protein loss. They might have intermittent blood or blood tinged urine. They might start having like swelling and noticing that their blood pressure is getting really high. So these are signs, but there's no necessarily, smoking gun. But when you get advanced stages of kidney disease, that's when you start having what we call uremic symptoms. And so the uremic symptoms are that your kidneys are just not filtering those toxins well enough. And so you start feeling really poorly. Patients start having fatigue, nausea, poor appetite. A lot of patients with end-stage kidney disease will just be like, hey, I just started noticing that my food just tastes really bland, or there's like this metallic taste in my mouth. They might start having weight loss. As the toxins build up, they might start feeling really itchy. And then they start developing fluid overload symptoms because you're not able to get rid of the fluid very well. They start to swell, they start having shortness of breath. And if you really wait very long, then people can really start to have sort of like uremic encephalopathies and get really confused. And family members might be like, all right, that's the final straw, we're taking you in. And then they get diagnosed with end-stage kidney disease. And so the treatment of kidney disease is largely focused at the underlying condition. And depending on what it is, it might require immunosuppression. So like lupus nephritis or IgA. I hear you're going to get an IgA talk later. So there are some kidney diseases that you will treat with immunosuppression. The other main thing is just to get, when there is no treatment and you have treated the underlying condition, is to prescribe the medications that have been shown in the literature to slow down the progression. And the two main are, I guess, three main classes of medications are, two of them are blood pressure medicine. So these are your angiotensin receptor blockers or ACE inhibitors. So these are blood pressure medications that have been consistently shown for a couple decades or longer to slow down progression of kidney disease. And then newly described the SGLT2 inhibitors, which are medications that are used for diabetes and now have been consistently shown to slow down progression. And there are a few other medications that have been shown to slow down progression in diabetic kidney disease as well. So having a good nephrologist who is aware of these medications and knows how to prescribe them and knows how to deal with complications that arise from these medications, because sometimes people will get high potassium levels, and that's not necessarily a reason to stop them. There are other ways to manage the potassium issue if that comes up. Other treatments, blood pressure is mainstay in managing blood pressure and making sure it's at target of less than 130/80. And then dialysis and kidney transplants are your final treatments for people who have continued to progress and have now developed end-stage kidney disease. So just really briefly, what is dialysis? There are two types of dialysis. One is just our basic hemodialysis, which can be done at a center where someone will go 3, maybe 4 days a week, and they're hooked up to a machine for 3 or 4 hours getting dialysis. Or sometimes you can also do it at home if you have the space and the ability to, maybe the support to do it at home. So essentially, it's basically a external filter. They take blood out of your body. You either need to have a fistula or a catheter. The blood's taken out of your body. It's drawn through this dialyzer filter, which basically removes the toxins and filters the blood. And then the clean blood gets put back into your body. And with the dialysis machine, you can also tell it how much fluid to take off. So if you have a patient who has gained 2 kilos since their last dialysis, and they have swelling, you can then tell the machine, set it up so that it takes 2 liters of fluid off of them. So you can set up your machine to do a variety of things. It's still obviously not as good as having native kidney function, but at least it helps to manage the symptoms, and people can live a long time on dialysis. Um, the other option is peritoneal dialysis, which basically uses your own natural peritoneum that's in your abdominal cavity as a dialyzer. And basically, you get a catheter that's placed in your abdomen, and dialysis solution goes in, and then just basic diffusion. The peritoneal membrane acts as basically the dialyzer here, and that is how toxins get filtered through, and fluid also gets filtered through. Um, okay, so that's just kind of basics about chronic kidney disease and end-stage kidney disease. Um, I think I just saw someone saying, what kind of fluid is the dialysis taking off? So it's basically filtering your blood, right? Your blood plasma. So basically that's what it is. That's what urine is. And so the next thing, I'm going to move on to talking about kidney transplantation, and not necessarily exactly in this order, but we'll touch on the history of kidney transplant and immunosuppression. We'll talk briefly about the kidney allocation system and how you become eligible for a kidney transplant. So dialysis is great. We're glad that we have that as an option, but kidney transplant is the treatment of choice for advanced. Sorry, I saw another question. Are there particular indications for hemodialysis versus peritoneal dialysis? So that's a really good question. So the majority of people in the US are actually on hemodialysis. So it's like 90% or so. And actually, most nephrologists will say that if they had a choice and they could pick a modality for themselves, they would pick peritoneal dialysis. So generally speaking, most people can do either or. There are some contraindications to doing peritoneal dialysis. So if for whatever reason you've had a lot of abdominal surgeries and your peritoneal membrane doesn't work, or it's been damaged or something like that, then you might not be a candidate for peritoneal dialysis. But really, the main thing about peritoneal dialysis is that it has to be done at home, and you need to have space to keep a machine. You need to be able to keep an area very clean. You need to have enough space for all the supplies, all the dialysis liquids that are used for peritoneal dialysis. And so, and then you might need to have some family support as well, but you get trained to do peritoneal dialysis yourself. And so a lot of people who are, high functioning and still want to be able to work will choose peritoneal dialysis because it's something that you can do during the day and carry on with your work. So basically, you just fill your belly with fluid in the morning, for example. You could still go to work and do whatever you need to do during the day. And then you come back home, you attach it to a bag, and you drain the fluid, and you've done your dialysis for the day. Or you could do it overnight, where the machine is basically cycling fluid in and out of your belly, or you could do a combination of these techniques. So there's a push towards doing more home dialysis options, either with peritoneal dialysis or home hemodialysis. But I, there's a lot of money that's made by dialysis companies, and so I suspect that, and there's also a lot of ease in going to a place where you just need to sit down. You don't need to think about anything, and someone just hooks you up to the machine and does the dialysis for you, and you go home. So there are lots of factors that probably contribute to the fact that there is such a huge amount of patients. But there are other places like in Asia where that's not the case, where the majority of people are doing peritoneal dialysis. And I think we can learn a lot from those systems, but there are some contraindications, but they're not that many to doing peritoneal dialysis. It's just how it ends up here in the US. So not drastically different. I think if you're getting adequate, so someone said, are health outcomes better for one type versus the other? I don't know all the literature on this, but not drastically different. I think if you are doing both dialysis adequately, then they're fine. Both of them are fine in terms of survival outcomes. I will say that peritoneal dialysis is a little bit better at preserving your own native kidney function. So, often when you start dialysis, your GFR is not zero. So maybe it's somewhere between like 8 and 12, for example. So you're still like, you still have some native kidney function. You're still making some urine. And that's actually beneficial because, like I said, the kidney is doing a lot of things that we actually can't fully replicate with the dialysis machine. So having that native kidney function can actually help you feel better longer, like taking care of toxins that we probably don't even know about that the kidney can help like filter, and just kind of helping you feel better. And then the other advantage is just being able to maintain maybe a little bit better quality of life. Like people who do hemodialysis will sometimes tell you like after their dialysis session, it's like they just feel really weak and really drained. They have to go home. They have to like rest for the day. And then the next day they're starting to feel better. And then the day after they have to go back to dialysis. So it's really, really very tough for quality of life. And so I think that quality of life is better with peritoneal dialysis. It's a more gentler daily form, more physiologic because it's like a gentle daily form of dialysis versus kind of putting all your dialysis into 4 hours, 3 days a week. Um, Okay, so moving to the history of kidney transplant. So the first successful kidney transplant was done by Dr. Joseph Murray at the Brigham um, in 1954. So he is heralded as the surgeon. He was actually a plastic surgeon, but he was heralded as the surgeon who performed the first successful human kidney transplant. And these are his colleagues, like standing next to him, Dr. Merle and Harrison. And the recipients were Richard and Ronald Herrick. They were identical twins, but Richard had developed glomerular disease that did not affect his brother. And, he really had come back from, I think he was in the Coastal Guard and got really sick and he really came home to die because there weren't really very many options. And even hemodialysis was still very rudimentary at that stage. And he was getting those sessions. But his primary care doctor was working with Dr. Murray and they were like, how can we make a kidney transplant happen? And they were able to successfully get a kidney from his brother and transplant it into him. And so he went on to live over a decade, actually, but he died from some reports say heart disease, other reports say recurrent kidney disease. But either way, this kidney lasted for much longer than any kidney had lasted up until that point. And his brother Ronald, I think, died in his late 70s. So this basically showed that you could be a donor who could give a kidney and still live a long life, and you could have a successful kidney transplant. But kidney transplants had obviously been happening experimentally up until 1954. So the very first successful experimental kidney transplant was done by Dr. Ullman in Vienna. He took a kidney from a dog and basically implanted it in the neck of the same dog and basically connected the vessels and demonstrated that that kidney was working, it was making urine, and the dog was surviving with the kidney in its neck it was making urine. So experimentally shown that you can take a kidney from somewhere and put it somewhere else. And then you move on to 1906, where there was the first human kidney transplant using xenografts. So basically, what they did is like I'm not going to say this like, probably Jaboulet. He took a kidney from a pig, another kidney from a goat, and put it in two human recipients and demonstrated that those kidneys did make urine. But obviously, for what we know, there are lots of immunologic barriers to doing that, and so those kidneys didn't last very long. They were gone, and the patients also didn't survive after like 48 hours or so. Then in 1933, Voronoi in Ukraine performed the first human kidney transplant with a deceased allograft. So he took a kidney from a 60-something-year-old person who had passed away and put it into a younger living recipient who had kidney failure. And that kidney actually the kidney actually didn't it made urine for a little bit, but it didn't work for very long. And so part of the reason why it didn't work for very long was the blood groups were not compatible, and back then people weren't thinking about compatibility, but that contributed to those kidneys not working. They were not the same blood group. And then you move on to the 1940s and 1950s, and there were other people experimenting with human kidneys from either deceased or living recipients. 1952 was the first use of a living related kidney donor in Paris by Hamburger and his colleagues. They took a kidney from a mom and gave it to her son. Unfortunately, they were not immunologic. There was no immunosuppression. I think the kidney worked for a few weeks, which was obviously a huge thing, but it didn't last very long because it developed early chronic rejection. So when we say the first successful kidney transplant happened in 1954, there were lots of experiments and transplants happening before then. But the reason why the transplant was successful was because they were identical twins. So there was no need for immunosuppression. So you took one kidney from Ronald, you put it in Richard. Richard's body felt like, oh, this is my kidney. It looks just like me. So it just accepted the kidney and there wasn't any issue. But afterwards, I think one of the important things in transplantation and what makes it possible was basically understanding how the immune system works. So in 1958, we had the first description of the human leukocyte antigen. And then, so understanding how the immune system works was one part, and we'll go into that just a little bit later. But then also having immunosuppression. So, like, not how many people have an identical twin that can give them a kidney if they end up having kidney failure? Very, not many. Very rarely will someone have an identical twin when they have kidney failure. So what you need then is like a way to prevent the immune system from rejecting the kidney. So in the 1960s and 1970s, basically you had the advent of immunosuppression, and we'll actually go over these a little bit more in detail later, but this is basically what it ended up contributing to the success for kidney transplant and other transplants today. And today, kidney transplants are the largest organs transplanted in the US and worldwide, and we'll go over that a little bit later. So I put this picture here because you may all have heard in the news of the first successful xenotransplant recipient. This was done this year. The recipient was Rick Slayman, who had kidney failure and had already had kidney transplants in the past that had failed. And so this was done at Mass General Hospital. I think he had also exhausted a lot of peritoneal dialysis options. So unfortunately, in order to be able to do dialysis, you need to have good vessels that can accept catheters or fistulas or a good working peritoneal membrane. So if you've developed if you've had a lot of accesses, your vessels can become scarred over time. Your peritoneum might not be working anymore. So you may not have an option to do any dialysis anymore. So usually when that happens, you're eligible for emergency listing for a kidney transplant. And I don't know all the specifics in this case, but it sounds like Mr. Sleeman had exhausted all his dialysis options and really didn't have an option for transplant anymore. And he was willing to receive a kidney from a genetically engineered pig. And so xenotransplantation is a whole topic in its own. And, I'm not going to obviously be able to have time to go over all of that. But what I will say is that the science has advanced to the point where you can actually genetically engineer a pig to look more similar to the human, so that this immediate rejection risk isn't there. And so the science has advanced to allow this to happen. So I actually think that xenotransplantation will be the future. I get a lot of questions about what about an artificial kidney, and there's been research in artificial kidneys for decades. I'm not sure that it's going to overtake the possibility of xenotransplant being what's next. But unfortunately, he only lived for about 2 months. I didn't really see what the cause of death was, but he was obviously a man who had lots of chronic disease, and I'm not sure that I think that that's probably what was his cause of death at the end of the day, but I didn't see that in any official report. But just so you're aware, and I think there was another xenotransplant case that was done a couple months after, and I believe that recipient has also passed away. So just a lot of things still happening out there. But in terms of your current options for kidney transplant, your main options are to get kidneys from either a living donor or to get kidneys from a deceased donor. And the advantages to having a living donor is really that those kidneys last longer. And you might wonder, like, why don't these kidneys last forever? They They just don't. Like a kidney that comes from another person's body, and we'll talk about like issues that can happen with the kidney. There's always going to be some sort of, either rejection that happens or infection that happens or reoccurrence of the original disease. And so what we find is that the average or median life expectancy for a living donor kidney is about 15 to 16 years. But the other advantage to having a living kidney donor is that you don't really have to go you don't have to wait a very long time for one. If you have a living donor that's willing to give you one of their kidneys, they just have to get evaluated and accepted for to be a donor, and then it's a matter of just getting them scheduled for transplant. And these kidneys typically are going to work right away. So once you put them in, they're working immediately. So deceased donors, so a kidney from someone who has passed away, is willing to be a donor and their family consents to donating their organs. Those kidneys are also a fantastic option. The lifespan's a little bit shorter. It's about 10 to 12 years. These kidneys may not work right away, so I always like to prepare my patients that once you get transplanted with a deceased donor, you might still need to do your dialysis for a few days or maybe a couple weeks, but eventually those kidneys will work, and you're able to stop your dialysis. And some of the factors that contribute to that is those kidneys are obviously coming from someone who has passed away, and maybe the kidney hasn't gotten good blood flow. The kidney might be coming from somewhere really far away, and so there are many hours outside of the body. So these are what we call cold ischemia times, and all of these can increase the risk of the kidney not working when it's put in. The largest downside to the deceased donor is, depending on where you are in the US, the wait time is really long to get a kidney transplant. In California, it's 4 years in the US on average across all places. It's shorter in some places and longer in some places like California. So the wait time, depending on your blood type and your immunologic risk factors, can be anywhere from 6 to 10 years. So really, really long. And most of the kidneys that transplants that happen actually come from deceased donors, which I'll show in a little bit. So to become eligible to get a kidney transplant, the criteria that we said, so we talked about the GFR and CKD stages. You have to have chronic kidney disease, and your GFR has to be less than 20 to be eligible, 20 or less to be eligible for kidney transplant. The advantage to getting on the list early is that you can start accumulating wait time. So I mentioned that the wait time in California can be up to 10 years for a kidney transplant. And every year you're on dialysis counts as 1 year. But if you were referred before you started dialysis, the time you were put on the wait list is when your wait time accumulates. So that's why I was saying early referral is super important. So if I can list someone when their GFR is 20 and it takes them 2 years to get down to 10 or whatever when they start dialysis, they actually have accumulated 2 years on the waiting list even before they started dialysis. So rather than waiting 6 to 10 years, then it might be 4 to 8 years, for example. The other eligibility is just that you're on dialysis. But the nice rule that we have now is that if you are someone, and this happens a lot, who started dialysis, but you didn't get referred for transplant for like 5 years, you've been on dialysis for 5 years. It used to be that the day that you were referred and put on the list is when you start accumulating your wait time. But because of the disparity, especially disparities that affected people who were maybe Black, Hispanic, and other ethnic minorities, in 2014, the allocation rules changed so that if you didn't get referred early, you weren't penalized. We would backdate your wait time to the day you actually started dialysis. So if you've been on dialysis for already 5 years, on the day that I see a person for the first time, they would immediately have 5 years of wait time on the waiting list and not have to wait an additional 10, for example. So as of today, I just pulled these numbers today. There are over 89,000 people who are on the kidney transplant wait list. And kidney transplants, these are the most numerous organs that are transplanted in the US. There are more people waiting for kidney transplants than any other organs. So I just highlighted just below, like the people waiting for liver transplants are about 9,000, people waiting for pancreas transplants just under 1,000, heart transplants about 3,500, lung transplants also under 1,000. So just to kind of put things in perspective, that it's by far and large the most numerous organ transplanted in the US and worldwide. And so, we put a lot of people on the wait list, but unfortunately, because the wait times are so long in certain parts of the country, people actually will die on the waiting list before they even have the opportunity to get a kidney transplant. And so this figure is from the OPTN, Organ Procurement Transplantation Network. They put out annual data reports with the Scientific Registry for Transplant Recipients. And it basically shows that what the death rates are. And not surprisingly, the older you are, your likelihood of dying on the wait list is much higher than a younger patient. And that's basically what this figure shows. And then kidney transplant volumes. So I just put volumes over the last decade here, but you can see that year to year, all donor types are both deceased and living combined for kidney transplants. Year over year, like there's been an increase. There was a slight dip in 2020 due to the pandemic, and there was some hesitancy in those early months, March, April, May, about like, should we be doing transplants? Is it too risky? Are we putting people at risk for getting COVID? Like, what are we doing? The transplant community was just a little hesitant at that time. So there was a little dip that year because of that. But overall, by May, June, most transplant programs were up and running and doing their living and deceased donor transplants at the same rates as they did previously, and just kind of figuring out the science as it went along. And since then, there's been a continued uptick in kidney transplants. And then the most transplants come from deceased donors. So over over 2/3 or more of kidney transplants will come from a deceased donor. And really the numbers for deceased donors has been largely kind of stable over the last decade. So anywhere from like roughly 6,000 to 7,000 kidney transplants come from living donors every year. And so just some practical aspects of kidney transplantation. So one is that you have to have good surgical technique. And, thanks to all the pioneers from the 1900s on who were transplanting kidneys from dogs to, other animals and between humans, I think the surgical technique has been refined and sort of perfected over time. And so the main thing in order to make this possible was people had to learn how to sew two vessels together. So advances in vascular anastomosis was critical for kidney transplant success. And then the other key thing for transplant success is donor and recipient compatibility. So, a lot of failure was really due to the fact that either the recipient and donor were blood group incompatible, or they were tissue incompatible, which is where the human leukocyte antigen comes into play. Is your body is going to recognize the blood group, it's going to recognize tissue markers, and if those are not recognized as being part of self, then your body's reaction will be to reject it. So these are the two practical things that you need to overcome in order to make transplant successful. And so here's just basic anatomy of the technique. So, the kidney is now placed. I mean, you can put the kidney anywhere and it will make urine. So long as it's getting blood flow and it can return the blood, it will make urine. You can put it in the arm, in the leg, but it just makes more sense to have it in the renal, in the pelvis area. And so basically you have the renal vessels attached to the renal artery is attached to the external iliac artery. So that's one anastomosis that's made. And then you also have your renal vein that's attached to the external iliac vein. So that's the vascular supply. And some kidneys will come with multiple arteries. So the more anastomosis you have to make, the more risk of possible surgical complications. But our surgeons are really good and they kind of know their way around this. And then the last piece is that the tube that makes the urine, that transports the urine, the ureter has to be implanted into the bladder. And so anatomically, this is a good location because it's close enough to the bladder to make this work. And so this is what the kidney transplant looks like. The other thing that we do to protect the bladder is put a stent in after transplant just to make sure that there's time for that bladder to heal, those connections to heal. And these are usually removed about a month or so after transplant and has reduced like complications with the ureter. All right, so beyond the surgical technique, the next thing to talk about was making sure you have a compatible transplant and making sure you have a good match. So the first barrier is to make sure the blood groups are compatible. So obviously, if you have blood group AB, you can get kidneys from anyone. If you're blood group A, you can get organs from people with blood group A and O. If you're blood group B, then you can get some from blood group B and O. And lastly, O, unfortunately, can only get organs from blood group O. So people with blood group O actually wait the longest for kidney transplants, and B is kind of like a close second. Um, and then blood group A, B, they wait the shortest, and blood group A is sort of in the middle there. Um, and then we're going to move on to talking about tissue compatibility. So I know, again, I have a varied audience, and, this is just key to understanding transplant immunosuppression. There is this landmark publication by Terasaki and colleagues in 1969. So again, the first successful transplant was in 1954, and then people tried to do transplants for non-identical donors, and they started to see that people were just rejecting kidneys. And so they went back to look at cross matches between recipients and the donors. And a cross match basically means that you took cells from the donor, so lymphocytes from the donor, and then you add blood from the recipient. You're basically looking to see, like, is there something in that blood that the cells from the donor is gonna not like? And so this was the first cross-match assay that was done. And what they found, like, that people who had a positive cross-match, those patients were more likely to immediately reject their kidneys and have failure. But if you had a negative cross match, the risk of immediate failure was much lower. And if you didn't have any antibodies, your risk for failure was even much lower at 2.4%. So having a positive cross match meant that you had an 80% chance of rejecting your kidney right away, and only a 2% chance of rejecting your kidney right away if you didn't have the antibodies. And the technology was still pretty rudimentary and not as sensitive. So that number really should be zero. Recipients without antibodies should be zero, but I think the sensitivity of the assay was not great enough to pick up all the antibodies that were leading to these immediate rejections. But immediate rejection is like non-existent, like in today's field of transplantation, because we're so good at performing cross matches and making sure we have the right blood group and making sure we're transplanting across, even if there are antibodies, that we have a plan to deal with those antibodies after transplant. So I don't want to go too much into the HLA system, but it is important in understanding rejection. So HLA stands for human leukocyte antigen. This plays an important role in immunity. It helps us to recognize, things that are foreign and not foreign. And so it has an important role in our immune system fighting infections and in rejection as well. There are two classes of HLA. There's HLA class 1, and it's present on all nucleated cells. And HLA class 1 will present foreign peptides to T cells, so CD8 positive cytotoxic T cells. And if those T cells say, okay, no good, it's going to destroy that cell. And that's partly how we, fight off infection. Like when our body gets something that it doesn't recognize, it processes it, it presents it to its T cell, and the T cell helps to get rid of it. And then HLA class 2 is present on antigen presenting cells, and these present extracellular peptides to CD4 positive helper T cells. So understanding the cross match, basically what I described that was done in that landmark paper in 1960 something was the CDC cross match assay, which was just further developed. And so basically, when you wanted to do a transplant, rather than just doing the transplant and seeing what happens, you could just say, hey, why don't we just take some lymphocytes from the donor while they're still here with us and doing fine, and add the recipient serum to them and see what happens. And if it's positive, then we don't need to go forward with the transplant. We already know that it's not going to work. And so that's basically what the CDC cross match is. And some centers actually still use this today, but there are more sensitive assays that are used. But basically, that's what this assay is. But the flow cross match is what we actually use here at Stanford, and it's a more sensitive assay, but it's the same idea. We basically take serum from the recipient, which might contain antibodies to the donor. We take lymphocytes from the donor, we mix them together, we add some fluorescent label antibodies against human IgG. And if there's a reaction, it's going to bind. If there's an antibody, it's going to bind. and it will get picked up by the flow cytometer, and you get a read, and it'll say, hey, you have an antibody to X, Y, and Z. So that's basically the flow cross match. Now, what we use, because we largely are transplanting deceased donors, and so what we actually use and primarily is something called a virtual cross match. And so when we see a patient in our clinic that's going to get a kidney from a deceased donor, we don't really know what that donor is going, what antibodies that donor, I mean, what that, if the recipient has antibodies to that donor. So what we do is we actually take the recipient serum and we try to figure out what antibodies do you have? Because if we know what you have, when a donor comes along, we're going to see if they have those things. And if they have those things, they're not going to be a match for you. And then we're basically going to look for a donor that does not have antigens for things that you have an antibody to, if that makes sense. And so this is basically an assay that uses synthetic beads that has different HLA on the beads. And you can add the recipient serum to these beads. And basically, it will tell you what antibodies the recipient has. It'll give you a read to say, hey, this recipient has antibodies to HLA-A, 1, B, 5, et cetera, et cetera. And you get a report. And anything that has a certain strength is considered a positive antibody. So just file that away for a little bit. But using this information of how many antibodies you have actually can help you figure out the immunologic risk for your recipient. So the immunologic risk is largely determined by these antibodies, these panel reactive antibodies. And the way people get antibodies is that they have had a blood transfusion before. And so they've been exposed to things that are not self. And so your body's reaction and the immune system is going to say, hey, there are things that I'm seeing here that's not me. I'm going to produce antibodies to protect myself from this. So when I see it again, I'm going to get rid of it really quickly. And that's why people can develop hyperacute rejections, is because they've seen that before. So the immune system is like ready to go the next time they see that thing again. Prior organ transplants can also cause sensitize. The word we use is sensitize a patient. Pregnancy. So a woman is pregnant, but half the baby is genetically someone else. And so pregnancies are sensitizing events. And so if women who've had multiple pregnancies are at higher risk of having high PRAs. And so it gives you this PRA gives you an idea of the percentage of the population that would actually be a match for a patient. And if you have a PRA number that's greater than 20%, it's sensitized. And I recognize this is probably like maybe over difficult to understand for a lot of people, but it's just like very integral to transplant medicine, is sort of understanding this. So if there are questions like these, let me know. But it basically helps you to determine your chances of finding a donor. And it also helps you decide what kind of immunosuppression you should be using and if you should use induction immunosuppression for that person. So when we get the information about what antibodies a person has, we basically put it into this calculator, which is available online if people want to play with it. So if I know that someone has an HLA-A5, B5, B3, whatever, you can put all of that information in here and it'll spit out a number. So if it spits out a number that says 20%, that means that 20% of donors will be a potential match. That means, sorry, if it says 20%, it means that you have antibodies to 20% of the population. That means that 80% or 80 out of 100 people will be available as a potential match. So I want to say that again because I think I might have confused even myself. But 20% means that you have antibodies to 20% of the population. So if you got a kidney from one of those 20% of people, you would reject that kidney right away. But that means that there's 80% of people that would be a good match for you. The higher this number is, the lower the possibility of finding a match in the general population. So having a PRA of 99% means that only 1 out of 100 donors will be a potential match. So that's not good. Those are patients that will be waiting a very long time for transplant because not a lot of people can be a match for them. And so the higher that 99% is, like you get to 99.99, your chances are even lower for having a potential match in the population. So this information actually helps us to understand like the likelihood of getting a match. And the allocation system now prioritizes people that are highly sensitized. So people who have PRAs greater than 90% because their chances of finding a match are much lower. They actually get a lot of points on the wait list. So I mentioned before that 1 year of dialysis equals 1 point on the wait list. And once you get to like 6 to 10 points, you're close to the top of the list for a transplant. But what we do is if you have a PRA of 99%, you get like 200 points on the wait list. So that person immediately shoots to the top of the wait list. That way, any organ that becomes available in the US is a potential, is going to be considered for that person. And it really just increases their chances of getting a kidney by doing that, by basically putting them at the top of the wait list so that as soon as something is compatible, they can get that organ. So hopefully that makes sense. So this is the CPRA sliding scale, basically showing that the higher your PRA is, the more points you get, and these points put you basically at the top of the wait list. So I think I'll skip over that. We can probably take a well, we can see if there are any questions, and if there are no questions, I think we can take like a 5 minute break, maybe come back about 10, 11 ish, and then we'll have just under 20 minutes to like finish up the last section.
Great. Thanks, Ade.
All right, everyone. So we're going to continue on. Um, Again, feel free to stop me if there are any questions. We're going to spend the rest of the time discussing post-kidney transplant and chronic immunosuppression management. Um, I probably will have to go through a lot of the rest of the slides pretty quickly. But again, if there's anything that's unclear, like feel free to stop me. So post-transplant management, a lot of it is like managing immunosuppression and complications of immunosuppression, which we'll talk about in a little bit. And then also managing metabolic complications that are either coexisting even at the time of transplant or develop after transplant as a result of the medications or other health conditions. And really like also managing respiratory infections, cancers, which are important causes of patient death after transplant. And so I wanted to highlight this because what we do is a lot of immunosuppression management, and just to kind of review from the earlier slides, that this slide is basically showing you the rates of rejection within the first year of transplant and the rate of patient survival in the first year. And what I really just wanted to highlight here was that in the early 60s and 70s, we didn't have a lot of immunosuppression options. So we had radiation, we had prednisone, we had 6-methaxypirin, and you can see that rejection in the first year of transplant was over 80%, which is extremely high. And patient survival was 40% or less. So what really changed the landscape of things was, one, the fact that we had better matches. We figured out how to give people blood group compatible transplants and do cross matches, so they didn't get transplants from people that were not compatible. But the other thing is, like, we saw that those transplants were done, but they didn't last very long. And the reason why they didn't last very long was because you needed another thing, which is immunosuppression. And so you can see in the modern era, like from the 2000s on, with all the immunosuppression that we have, patient survival is like way over 95% now in the first year. And rejection rates are actually like 5 or 6% in the first year. So we have come a very long way in the last several decades. And so I think I'll skip, not spend too much time here, but we talked about the HLA, and we talked about how antigens are presented and recognized by T cells. So sort of an understanding of how T cells are activated is important in understanding how rejection happens. You need three main different signals between the cell that's presenting the antigen. So in this case, the peptide from the donor to the T cell, and the T cell is going to recognize that as foreign. And if you don't do something to block this, the T cell is going to activate cytokines and all kinds of things that are going to lead to destruction of the allograft. And so if you are a drug development company, you really kind of want to understand this process, because basically these are how the drugs have been developed to target different parts of this system that leads to rejection. And so a lot of the medications that we use are one of these medications presented in these slides, and they just work at different parts of the T cell activation pathway. And so the way to think about immunosuppression, there is induction immunosuppression. Induction immunosuppression is what we use up front. And basically, this is really intense immunosuppression to prevent rejection really early on. So we're really getting rid of a lot of the lymphocytes and the T cells that are implicated in rejection. And then there's maintenance immunosuppression. So, induction immunosuppression typically happens at the time of surgery, during the transplant hospitalization. Maintenance is what you go home on and basically kind of keeps things at bay so that they don't cause problems in the long term. And so we have just a few options for induction immunosuppression. There are interleukin 2 blockers, and then there are lymphocyte depleting agents. Most of people in the United States will actually be getting a lymphocyte depleting agent like rapid antithymocyte globulin. These are basically medications that target T cells. Alemtuzumab, which is the last one on this list, targets both T and B cells. And so that's what we do upfront to kind of protect you from rejection. And then maintenance immunosuppression is what you'll take when you go home. So these are pills, and there are different variety of pills, but most people are on either 2 or 3 of these drugs. And primarily the top 3 are the ones that are used. But if there is some complication or intolerance, that's usually when we consider the mTOR inhibitors and the co-stimulator blockers like belatacept. So these are the medications that are used today to prevent rejection and also to treat rejection. And so the people who get induction immunosuppression are people who are higher risk. So we talked about that PRA over 20%, meaning, that also means that you're a group that's seeing things that doesn't belong to you. So your risk for rejection is higher. If you've had a prior organ, the literature has shown that people who are of African American descent are higher risk for rejection. People who have this delayed graft function or are getting kidneys that have been on ice for a very long time. These are patients that are higher risk for rejection. So these are the ones that when you come in the hospital, we know we're going to give you induction right away. If you're in a low risk group, we actually don't have to give you induction. We can just rapidly get you on the maintenance drugs and try to get them to therapeutic levels as quickly as possible, definitely before you leave the hospital. And so this graph just basically shows in the US what people get. And the green line is basically people who get the more potent induction immunosuppression. And most people, more than 60%, closer to 80% now, will get this agent because they're so good at suppressing the immune system up front and preventing rejection. I'll skip over this slide and we'll go straight to maintenance immunosuppression. So calcineurin inhibitors are basically the first line drug that are used to prevent rejection and is part of the maintenance immunosuppression regimen. So tacrolimus, which comes in different types of formulations, Prograf, Invarsus, Astrograf, these are initiated at the time of transplant and continued on at home. Mycophenolate is the other first line agent, anti-proliferative agent that's used to prevent rejection. So people are usually going home with tacrolimus, some sort of mycophenolate, and then they go home with a corticosteroid, so prednisone. So those are usually the three drugs. We try to get the steroids off because of risk of side effects of being on steroids for a long time, but there are some cases where we won't. If you are high risk for rejection, we won't take off steroids. If you have kidney diseases like IgA, lupus, FSGS, or other glomerular types of diseases that are known to be steroid responsive, we typically will keep the steroids on. And so this basically shows you a graph of what people are taking in the United States. So that purple line up top shows you that more than 60% of people are on three drugs: tacrolimus, mycophenolate, and steroids. And then a close second are the green line, tacrolimus and mycophenolate. So that's basically like 90% of people in the US are on these medications if they have an organ transplant. And then other people who can't tolerate those medications might end up on something else. And so I showed you that graph that shows we're pretty good at preventing rejection in the first year. But what we're not good at is I told you that these kidneys don't last forever. So like they're lasting 10 years for a deceased donor, maybe 15 years for a living donor. And that's just because there's lots of things that's happening after transplant that causes damage to the kidney over time. So this figure basically shows the probability of finding some abnormal finding if you were to biopsy a kidney at different time points after transplant. And what they basically showed is obviously in the first few weeks to few months after transplant, if you biopsy a patient, you're not going to really find a lot of abnormalities, right? So no major abnormalities. The probability of not having anything is pretty high early on because we have really good induction immunosuppression, really good maintenance immunosuppression. But on the bottom of this chart, if you biopsy really early, you have lower risk of finding things like borderline rejections, T-cell mediated rejections, polyomavirus infections. These tend to be like low level, but possible within the first year. But as you go on, so beyond 5 years of transplant, if you biopsy people, you're less likely to find like acute T-cell rejections and borderline rejections. If you've made it to 5 years, it's not usually rejection, like acute rejection is not usually the issue, but there is one type of rejection, antibody-mediated rejection, which is very difficult to treat. And that tends to be a high finding in late transplants. And despite the medications that we use, we're still not very good at preventing the immune system at fully developing an antibody that's going to get rid of that kidney. But other things that you can find is glomerular diseases that have come back. So if somebody had lupus, their lupus could come back. If they had, FSGS or IgA, all of these things can come back. C3 glomerulopathies, these can all come back after transplant and damage the kidney. So, we always tell people like, whatever caused your own kidneys to fail, that can happen again to the transplant. And those things tend to be seen later on. You can also have a lot of atrophy, rejection, but what you see more is just the glomerular diseases coming back, and one type of rejection that we just have a really hard time preventing, which is the antibody-mediated rejection. And so another complication, we're constantly monitoring our immunosuppression after transplants because these medications can have complications. People who don't have diabetes can then develop diabetes because they're on these medications. So the steroids, the calcineurin inhibitors, the mTOR inhibitors can cause that. They can develop dyslipidemias, hypertension, and of course, all of these things can also lead to kidney disease. There are a lot of bone problems that can develop after transplant. We're already dealing with a high-risk population for that. Anemias, leukopenias are also side effects of the anti-proliferative agents like azathioprine, mycophenolate. Delayed wound healing can happen. Patients can have stomach issues, diarrhea, nausea, vomiting. So sometimes we have to change their immunosuppression as a result of that. They can develop proteinuria, and they can also develop, believe it or not, like the best medication for preventing rejection over time can cause scarring to the kidney and lead to decreased GFR over time. So that's just another consideration, is making sure we're monitoring these medications and making sure that they're at the right levels. So we're constantly balancing the toxicity profile of these medications with their ability to prevent rejection. It's like a constant thing that we're doing. So rejection, as mentioned, is just an important cause of allograft failure. But, even though we've reduced acute rejection in the first year of transplant, this hasn't really translated to long-term allograft survival. There are lots of risk factors, which we've sort of covered a little bit, just being highly sensitized, having antibodies. If you're Black, if you got transplants from a blood group incompatible person, we do these transplants now because we have immunosuppression to sort of overcome them, but the risk for rejection is higher in those groups. If you've had a prior rejection episode, if you're not getting the right amount of immunosuppression, all of these things lead to rejection. And as I talked about earlier, the hyperacute rejection is really not seen anymore. If it happens, it's because you had a preformed antibody that somehow didn't get detected, or you got a blood group incompatible transplant. But what we do see is the acute T cell and the chronic rejections at different phases of transplant. So kidney transplant surveillance, we basically are seeing patients very often and getting blood testing at various time points to really monitor their kidney function. So in our clinics, for example, in the first month of transplant, we see patients twice a week, and we're getting blood and urine tests, medication level testing, just to make sure that things are working the way we are. We're also at different time points getting blood tests to monitor for infection, blood tests to monitor for different types of infection like BK virus, CMV virus, and also looking for metabolic complications of transplants like developing diabetes, hyperlipidemia, problems related to bone mineral disease, etc. Other things that we can do after transplant is antibodies are really implicated in causing these long-term rejections. So you can have mechanisms for monitoring them over time. We typically are not giving a transplant to someone who already has an antibody to their donor. We can, but we typically are not doing that. So we can monitor patients over time to see if they are developing new antibodies that were not there. That's an indication that they're not getting enough medications, and there are things that we can try to do to get those antibody levels down. There's also new testing that we can do. There's one of the testing comes from a company called KRDX AlloSure. Basically, you're looking for DNA from the kidney, and it's a blood test that we can easily do. And we send it over to the company, and they can tell us if they are finding DNA from the kidney. That's obviously not good because it means the kidney is getting damaged somehow, and now the DNA is leaching into the blood, and that's how we can pick it up. So when this test is negative, is very reassuring. When it's high, then that's when we're worried that there could be a rejection or something else going on, and then we have to move on to doing a biopsy. So biopsy is really the gold standard for detecting problems with a kidney transplant. We obviously can have our suspicions about what's going on, but if you think someone's rejecting, or if you're not sure, could this be an infection or something going on, then you might have to do a biopsy to figure that out. So that's done very commonly in our patients. And then in the long term, once you get beyond the risk for rejection that's highest in that first year, but persists, long term, um, uh, and I'm not sure if I was just very clear that there are two types of rejection, the cellular and the antibody. So the antibody tends to be a long-term phenomenon, but the cellular rejection tends to be the highest in the first year and usually goes down over time. But other long-term complications of having a kidney transplant is heart disease, infection, and cancer. So these are also things that we're monitoring and making sure that people are on appropriate medications and screenings to prevent these. And so this is just the publication that looked at all-cause death among kidney transplant recipients from 1996 to 2014. And they showed that the highest cause of death in kidney transplant recipients was cardiovascular disease. So about 25% of kidney transplant recipients died from that. And then infection was a second cause at about 15%. And immunosuppression does cause obviously prevents your own natural anti-cancer mechanisms, and so the risk for malignancy is also higher in transplant recipients. The all-cause malignancy rate was about 3%, but we know things like skin cancers develop at much, much higher rates in transplant recipients, and so we're often getting our patients screened for these. And so I think I will skip over these. We're getting close to time. So just very quickly, we do a lot of blood pressure management. We use typical blood pressure medications. We avoid certain things early on just because they can cause acute kidney injuries. So things like ACE inhibitors and ARBs, which are fantastic medications, but you just want to use them once you know the kidney function's working really well. And diuretics as well. You don't want to dry the kidney out. That can also cause AKIs. And so we're careful about the drugs we select early on, but later on, we're able to introduce the diuretics and the ACE and ARBs once things are stable. Diabetes and cholesterol management is also an important thing, just because these are risk factors for cardiovascular disease as well. So we're targeting A1Cs less than 7%. We're making sure patients are following up with their endocrinologist or primary care doctors. We're also checking their cholesterol levels and making sure they're on a statin if they need to be, just to modify that risk. And then the other part of this is the infectious risk. We educate our patients. We put them on certain medications in their first year of transplant to prevent common infections like CMV, HSV, hepatitis B, tuberculosis prophylaxis, fungal prophylaxis. This is all offered in the first year. And then we also vaccinate our patients. So I won't have too much time to go over UTIs, but they are common after transplant. We will treat people who have complicated UTIs, but if they're asymptomatic, our practice is not to treat them, but this is something that we monitor for. We get urine testing pretty much with all of the labs that they do. And part of the reasons why people are at risk for UTIs that can develop into pyelonephritis after transplant, meaning that it goes into the kidney to infect the kidney, is because there's not a natural valve between the kidney and the bladder. We can't create that natural valve that we're born with. Our surgeons have mechanisms to kind of like suture things in place to kind of prevent reflux from happening. But if the urine in the bladder is infected, that can easily go into the kidney and cause an infection in the kidney as well. So we put people on certain antibiotics that can provide UTI prophylaxis in the first year. And beyond that, we basically treat if they're symptomatic. And then one other main viral infection that causes a lot of problems after transplant is this virus called BK. BK, a lot of people get it when they're younger. They have like a URI, upper respiratory infection. The issue is that it likes to stay in kidney tissues, and in healthy people, it's not a problem. But after you have a transplant and you're immunosuppressed, the virus can start multiplicating and going into the urine. From there, it can go into the blood. And once it's in the blood, there's about 1 to 10% of people who have it in their blood will end up developing BK nephropathy, which can cause them to lose their kidney function. So that's basically, I think, what I will go over for BK. The last part of this talk is just to talk about vaccination, because this is an important tool for reducing infection in our transplant patients. So we're constantly encouraging and reminding our patients to stay on schedule for vaccinations. The only vaccines are not allowed to receive are live attenuated vaccines, just because of the theoretical risk of causing infection, although that's not been clearly demonstrated in the literature. So because of time, I'll skip that. The only cancer screening is basically the same as the general population. The only additional cancer screening that's not general population screening is skin cancer screening. And that's just because being on immunosuppression. So whether or not you have a transplant, if you're a patient who has a rheumatologic disease and gets a lot of immunosuppression as well, like your risk for skin cancer is just significantly higher. So we're constantly counseling our patients about skin protection, using SPF, wearing hats, clothing, protective clothing, and also seeing a dermatologist once a year. So I will stop there. Sorry, I rushed through the last slides. You guys are welcome to have these slides if you'd like them. But yeah, I'll stop there.
Thank you. That was fantastic. Really comprehensive. I know you covered a lot of information in our hour and a half together. So thank you for a fantastic talk today. And thank you guys for joining. So I will stop the recording now.